Hello, this is our 113 emergency room design presentation by
Breighlynn, Madsen.
Imren,
Amelia, Nguyen.
Lianne, Valera.
Vigel.
So hi, I'm Amelia, and I'm here to discuss about the issues in the ER room and the reasons behind it. So the following issues are hallways being too congested or crowded, a slowdown for care of patients when a trauma patient comes in, the tedious and heavy movement of equipment being dragged around, lack of staff coverage, and limited tracking of locations for all patients. The reasons why they need to be addressed are important since some patients can be contagious and could increase the risk of spreading disease or infection to patients. They could leave the building without notifying staff, or staff cannot keep an eye on them at all times. There's a lack of staff to help around and too much bulky equipment to move around, and this may cause injury to other patients that are wandering around. According to Dr. Dan on kevinmd.com, most of the current IT systems are slow, cumbersome, and inefficient, meaning that most technology systems in hospitals are not up to date and cannot track all patients' locations. This may all lead up to patients hurting themselves or not enough staff or specialists to cover all patients needed. Next, I'm going to be talking about the first draft on paper. The first draft was like on paper and is a layout of a hospital room and is a basic and simple layout for like a hospital room. There isn't much, but there is around 2 separate rooms for beds for patients, 1 full OR section, and 2 main hallways. This was just all of draft to follow up and elaborate more on, since we were still planning on how to address the issues I discussed it and put it into the design layout.
So this is our first electronic draft, and we added wider hallways to prevent congestion, added beds into 3 triage categories for patients, added a staff room, added a supply room, and added another hallway.
This is our final ER layout, and some changes we made that address our issues include triage areas separated into rooms and beds. This creates a more efficient use of space. Some of the 8 rooms for the non-urgent area and the 10 rooms for the urgent and emergent areas have 2 beds that can be separated by curtains, such as room 7 and room 2. The 5 wide hallways address the issue of hallway congestion and allow for easier transportation of patients and equipment. Employees can also get from place to place much faster, solving the issue of slow care. More patients can be admitted faster, decreasing their time in the waiting room. The wide hallways make the transportation of large supplies safer and more efficient. Next, we address the triage center, which is located in the middle of the ER with hallways going around for smooth employee and patient transportation from any room to another. All the intersections are located on the edge of the triage. There are 4 intersections located on the edge of the triage center, which allows for easy intersection and makes hallways easier in the ER. The next issue is the trauma area of the ER is separated into 4 operating rooms labeled trauma 1, 2, 3, and 4. There is also a supplies room right above the operating rooms. Directly outside of these rooms is the ER's largest and widest hallways. Chaos will be avoided and large supplies can have room to be transported. There are 3 hallways going from the front of the ER to the trauma rooms, radiology rooms, and supply rooms, all located in the back of the ER. Each of these hallways either run through the triage beds or the ambulance bay. If patients are brought in and immediately need to go to the OR, there is a straight path from the entrance of the trauma rooms, and all the paths going toward the ER are straight paths which avoid the chaos of turns and busy intersections.
As for the emergency room, we decided to go into detail for the triage. Triage rooms are used to rate a patient's clinical urgency. We categorize the triage room to meet different levels of priorities of the patients as emergent, urgent, and non-urgent. Patients are sent to the stations to be assessed according to their severity. and they are brought to their rooms based on what triage they fall into. This is more of a centralized way of figuring out who's in the ER where they can optimize their time. The triage room consists of the physician and nurse computers, which are an effective way for the issue of limited tracking. Across the wide hallways are digital media records where there are all electronics stored in a database. It keeps the hospital more organized through this manner as patients can be located quicker. Through improved technology, digital databases could be used to sort patients quicker since it is all online. With patient assessment and the physician and nurse center located directly next to each other, the triage and patient rooms and where they will be relocated into the ER can immediately be communicated into the system. With 3 assessment rooms, the rush of patients is easier and it is more centralized and accessible for the staff and the patients as they are prioritized according to their needs.
Our first innovation in equipment, devices, and organizations is the touchscreen ER map. This ER map is located in the triage room. It is a large digital illuminated touchscreen map of the ER that allows physicians and nurses to see the status of the patient in each bed, estimate the time of the patient in the rooms or beds, see the availability of the beds, radiology, OR rooms, and equipment, and it is also interactive. It can record when a new patient is on a bed and who is treating them. And with an employee ID, access of the patient name and their status is available so they could look it up on medical records on the computers located in the triage room. According to Northwell Health and John D'Angelo, MD, a prominent issue in emergency room efficiency is access to emergency medical records. The board, along with the triage room's digital database, gives physicians and nurses easier access to these records. The secure digital database communicates with other technology systems, working with the patient's main care hospital to keep record of their electronic and medical record. These records can then be accessed through the emergency room computers for patient care, also located in the center of the ER. When a physician scans their ID on the board, they can quickly view the name of the patient as it pops up on their handheld device, so it cannot be viewed by anyone passing the board. The employee can then relocate to the computers to search for the electronic medical record and immediately access a patient's medical history that has been collected over time. This is an example of what it looks like when you click on one of the rooms on the touchscreen ER map. So this is an example showing the urgent room. It has the total number of beds with the number of patients and available beds, the section to scan your physician ID, the estimated time until the next availability, and these rooms can all be clicked to access information using the physician ID. This is our innovation on the mobile device. A mobile device is given to each physician and nurse, and it shows the capacity of the patient location on a handheld device. This can be attached to their waistband of their pants, and it is the same map from the same large ER map located in the triage room that is shown on the device, and this is so they know where to focus their attention to in terms of communication and priority, and each handheld device is linked to a physician's ID that they scan. Each employee ID is synced with their mobile device, the board will scan who is trying to access the room details and sends the details, which include the name of the patient occupying the bed, directly to only that employee's device. This way, patient privacy is preserved and HIPAA remains unviolated, as the patient's name cannot be seen by anyone who passes by the ER map board. This ensures that the privacy of the patients in each room and bed is respected and maintained.
Another innovation my group and I discovered was the use of telemedicine. This way, patients are monitored efficiently, and it's an easier way to communicate from patient to doctor. Telemedicine platforms could help treat patients in terms of emergency and can create closer connections to certain departments. Today, we are very reliant on technology, so certain apps that monitor someone's health and make accessible ways to contact doctors could be an effective way to deter instability. These could improve wait times and satisfy patients to make sure they are meeting the right people in terms of triage. Since there is a slowdown in care in emergency rooms, this could be a small way to keep an eye out on patients who are at risk for blood sugar, blood pressure, and heart rate. This could also lead to more efficient ways of checking in on people via technology and online forms. Large health systems such as the University of Mississippi Medical Center use telemedicine to help smaller hospitals treat ER patients. A study of 15 of the state's hospitals using telemedicine to treat 500,000 patients saw 25% reduction in staffing costs, while their admissions had a 20% increase. So using telemedicine also allows people to consult and connect with their doctor. So with this, they are improving patients, and this is a better virtual primary care way. If more patients can access primary care providers, even virtually, there may be fewer patients using the emergency department for primary needs. Even today, like in situations such as COVID, telemedicine can be an efficient way to deal with certain situations in hospitals in order to lessen waiting time and prioritize their patients' needs. So another thing we found was copper equipment. According to the medical journal, copper oxide in medical devices and consumer products that researches medical devices, 80% of infectious diseases are transmitted by touch. In the US, almost 5% of patients admitted contracted disease while in the hospital. For patients admitted in the ICU, the number increases by 25%. From research, greater than 99% reduction in bacteria was realized in lab results. From clinical trials, there's an 83% reduction in bacteria from copper alloy components. And with that, there was a 58% reduction in infection from things that were made in copper, and transmission was way less. So copper services reduce superbugs, which is an innovation that could help change the medical world for better in terms of infection control. Standard materials such as steel can harbor bacteria, and if it's not cleaned properly, it could lead to the growth of pathogens. With copper surfaces, they can kill this bacteria and destroy potential microorganisms quickly. This could solve issues with contagious patients that could contaminate in areas and hospitals, and this innovation could reduce this transmission. So some ways of incorporating it would be bed railings, door handles, and knobs. They are found all throughout the hospital, and they're touched by patients by all parts of the facility. So using copper handles could prevent the certain spread of diseases. IV poles could also be made out of copper because they're moved around by the staff and the patients. This could reduce the risk of infection for everyone. Faucets could also be used be made out of copper, because that way because infection can survive in droplets. With copper alloy faucets, they create a hostile surface for the microbes, which reduces the risk of infection.
These are the original number of staff worked in the ER before making a revised schedule. With this few numbers, changes need to be made because patients were having to wait hours to be seen by any physician, sometimes causing their condition to worsen. Also, at times, tough calls had to be made about who was in a worse condition and had to be examined more urgently. Our goal for our revised emergency room is to hire more physicians, nurses to exceed the number of patients coming in at each shift, so these tough calls don't have to be made again. This slide shows how many patients are coming in on the average week during certain hours and shifts. By tracking all the patients that come in through the day and the times they come in through at, when we go to make a new and improved schedule, it'll be more accurate with the schedule when we schedule a certain amount of doctors for each shift. This diagram also makes it easier for us to visualize what the doctor to patient ratio must be in order to have an effective emergency room.
According to a 2018 survey by the Physicians Foundation, doctors on average work 51 hours a week and see 20 patients a day. And according to a study conducted by Wolters Kohler, the nurse-to-patient ratio in a critical care unit must be 1 to 2 or fewer at all times. and the nurse to patient ratio in an emergency department must be 1:4 or fewer at all times that patients are receiving treatment in the state of California. From this information, we adjusted the numbers of our staff to meet that ratio in each room in the hospital per shift. This adjustment of staff ensures there's enough staff to treat and provide aid to the patients until they are healthy. In addition, we added a specialized staff to work on trauma patients so they would receive the care they need immediately. These tables on this slide and the next two slides show how many medical workers are assigned in each room in the hospital. These assigned rooms ensure that we have enough staff members to take care of the patients in each rooms of the units. The table on the next slide also helps the issue of slowed down care when trauma arrives by making sure there's enough staff working in the trauma rooms. By assigning physicians, nurses, surgeons, etc., to the rooms in each unit, it helps us know where the patients are and the staff needed to assist those patient needs.
This is our new staffing schedule numbers for each position and room in our ER. When compared to our original, you can see the drastic change in numbers of each department of our emergency room to make sure there's a significant doctor-to-patient ratio. This also helps avoid problems of patients having to wait an absurd amount of time before being seen. This is just a more detailed schedule listing specific physicians and what days they work throughout a random week and what time and shift and unit they will be working.
This is a schedule for the physicians working in the non-urgent bed units. This schedule helps solve the problem of the staff shortage by ensuring there's enough physicians working during each shift to care for the patients. And the next schedule is for the nurses working in the non-urgent beds. This schedule also helps solve the problem of the staff shortage by ensuring there's enough nurses working in each staff shift to care for the patients.
And this is our works cited from all the sources we use to help build our innovative ER. Thank you.